Hello, everyone, and welcome to today's webinar titled Update on Emerging HIV Resistance to Integrase Inhibitors, How Concerned Should We Be? I am Dr. Obiageli Okafor, and I'll be your moderator for today's event. Today's educational webinar is presented by Lab Roots and brought to you by Thermo Fisher Scientific. To learn more, visit www.thermofisher.com/HIV education. Again, www.thermofisher.com/HIV education. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of this presentation. Also, if you experience any technical questions or have any technical difficulties, you can utilize the QA box and we'll assist you directly. Now, I'd like to welcome our three speakers. First, we'll have Dr. Bilaal Wilson Matola, who is a HIV Care and Treatment Program Officer of the Department of HIV/AIDS, Ministry of Health, Malawi. And then we'll have Dr. Leonard Kingwara, who is the head of the National Genomics and Molecular Surveillance Laboratory at the National Public Health Institute in Kenya. Dr. Matola and Dr. Kingwara will share with us findings from their national surveillance program and some clinical data on the levels of integrase inhibitor drug resistance in their context. And then we'll finally invite Professor Francois, who is the Executive Director of Azincha at the University of Witwatersrand in South Africa. He will zoom out on this topic and discuss fundamental points related to emerging HIV drug resistance, particularly to dolutegravir. For complete biographies on our speakers, please visit the Biography tab at the left of your screen. Dr. Matola, you may now begin your presentation.
Hello, this is Dr. Bilaal Wilson Matola from Malawi Ministry of Health. Yeah, I work with the Ministry of Health Department of HIV, and I'm the officer responsible for HIV drug resistance monitoring. Yeah, I would like to welcome you to this Lab Roots webinar on update on emerging HIV drug resistance to integrase strand inhibitors. Yeah, how concerned should we be? Yeah, and I'll take you through the programmatic update on how HIV drug resistance is being monitored in Malawi. So this is my disclaimer. Yeah, and this is the outline of the presentation. Yeah, first of all, yeah, I'll take you through the status of the HIV epidemic in Malawi, of course, followed by how the program is performing. Yeah, and then we'll look at the structure of HIV drug resistance monitoring in Malawi. Yeah, and of course, the two papers that we published, and then we'll also look at the dolutegravir resistance surveillance that we conducted in 2022 to 2023. Yeah, and towards the end, we have a few summary of key points. Yeah, so to begin with, in terms of the HIV epidemic status in Malawi, yeah, as of 2023, as a country, the population was at 21 million plus. Yeah, and out of that 21 million plus, we had a million plus people that were living with HIV. Yeah, giving a prevalence of 4.8. Yeah, but now considering that the HIV epidemic in Malawi is mainly heterosexually transmitted, yeah, it's important to look at the prevalence based on the population that is sexually active. Yeah, and that is the population that is aged 15 years and above. And if you look at that, yeah, as of 2023, there was slightly above 12 million people in Malawi as a population. Yeah, and out of that, 954,000 were people living with HIV, and that was giving a prevalence of 7.7%. So out of that, a million plus people that are living with HIV, as of end September 2023, yeah, the program in Malawi has managed to diagnose 95% of those living with HIV about their HIV positive status. And the program has also managed to put 99% of those that know the HIV status on ARVs. and they have managed to achieve 95% of viral load suppression for those that were on treatment. Yeah, meaning to say, as of end September 2023, Malawi as a country had achieved the UNAIDS 95-95 fast-track targets. Yeah, and if you look at these people that are living with HIV and are on treatment, yeah, 99% of all the people that are on treatment, they are on a dolutegravir-based regimen. Yeah, the biggest chunk, which constitutes 98%, is on tenofovir, lamivudine, and dolutegravir. And then the pediatric population, the majority of them are on abacavir, lamivudine, and dolutegravir. And we have a small proportion in the pediatric population, yeah, that is on zidovudine, lamivudine, and dolutegravir. So in terms of who is eligible for HIV drug resistance, according to our 2022 guidelines, yeah, so every patient who is on dolutegravir and a protease inhibitor base regimen who do not suppress below 1,000 copies after an initial high viral load, despite good adherence, those are the patients that are eligible for HIV drug resistance testing. So in terms of how the structure works, we have a national care and treatment technical working group, and then under this technical working group, we have a number of sub-technical working groups, and one of it is the HIV drug resistance expert committee. And in that committee, we have clinical experts, we have laboratory experts, and we also have an administration team. Yeah, this administration team is the one that acts like our secretariat in terms of receiving applications from attending clinicians and, of course, communicating whatever information is required to the experts. So as a process, the process starts at the health facility where you have an attending clinician who has a patient who meets those criteria. That is either on a dolutegravir-based regimen or they're on a PI-based regimen, and they have a second high viral load after the initial high viral load, and they have undergone the intensive adherence counseling. Yeah, so when an attending clinician has such a patient, they're supposed to fill a form, an application form, and then that form is sent to the third line secretariat, and the secretariat shares that form with the HIV drug resistance experts who review the application and make a recommendation whether to proceed with HIV drug resistance testing or maybe to have another session of adherence counseling. And when the application is approved, the attending clinician will collect a sample from the patient, and that sample is sent to the HIV drug resistance secretariat, and then afterwards is sent to the lab. And when the results are ready from the laboratory, they are sent back to the secretariat, who then communicates to the HIV drug resistant experts. They will make the treatment recommendation, and then that treatment recommendation will be communicated to the attending clinician at the facility. And of course, that will inform the patient management at a facility level. So based on our data from November of 2019 to September of 2020, we just looked at our data and reflected on how we are performing as a country. So in that period, we had 6,500 patients that were eligible for HIV drug resistance testing. That's according to our definition. And then from this cohort, we only received 87 applications. Yeah, and after that thorough review by the HIV drug resistant experts, only 33 applications were approved. And those ones are the ones that resulted in sample collection. Yeah, and out of the 33 samples that we sent to the lab, out of the 33 samples that we sent to the lab, 27 samples were successfully sequenced. And from those 27 samples, we had 8 patients that had HIV, that had dolutegravir drug resistant mutations. Yeah, and then we also conducted a similar analysis, but now covering a longer period. So we covered from July 2019 to October 2022. Yeah, in this analysis, we also looked at the outcomes for those patients that have been switched, that's after being found with dolutegravir resistance. So in this second analysis, we had a total of 317 applications that we received. And out of the 317 applications, we had 161 that were approved. And from 161, we had 119 that managed to send samples to the laboratory. And we got results for all those 119 samples. Yeah, and from the 119 samples, we managed to get a successful sequencing for 98 samples. And then for Integrase, we managed to get a successful sequencing for 89 samples. And out of those 89 samples, 24 patients had dolutegravir resistance mutations. So if we look at the mutations that were found in these populations, we had E138K, that one was present in 16 out of the 24 patients. And we also had R263, that was present in 16 out of the 24 patients. And E138K, that was present in 7 out of the 24 patients, and G118R, that was present in 6 patients out of the 24 patients. And then when we conducted multivariate logistic regression analysis, we noted that older age and the presence of high-level NRTI resistance were significantly associated with dolutegravir resistance. So we followed up those 24 patients in terms of now the outcomes. So 4 individuals from those 24, they died after getting the diagnosis. And then we had 3 patients that we lost through attrition, either a discontinuation of VRT or some that transferred out, and then we are not able to track them. Yeah, and we had 17 patients that were remaining, and out of these 17, we managed to trace 12 that had follow-up viral loads in the system. Yeah, and 11 out of the 12, we noted that they had managed to suppress their viral load below 1,000 copies, and that represents 92%. Yeah, so in conclusion, we concluded that 24 cases with dolutegravir resistance among 89 individuals with confirmed virologic failure suggests a considerable prevalence in the Malawi HIV program. Yeah, and in terms of the bottlenecks that were there, you might have noted that there is a big attrition between the applications received and the actual number of samples that are sent to the laboratory. So we have a number of bottlenecks, some that are to do with the clinician, and then some that are to do with the health system that we are operating in as a country. Yeah, on the ones that are related with the attending clinician, yeah, we have issues to do with insufficient guidelines knowledge, and of course, low motivation to complete that application form that I mentioned about. Yeah, on the system-related issues, yeah, we have a long viral load results turnaround time as one contributing factor. Yeah, and of course, we also have a long HIV drug resistance testing results turnaround time. Yeah, this is partly contributed to inconsistent in-country HIV drug resistance testing that we have experienced as a country. Yeah, and the reason for this was failure to access HIV drug resistance testing reagents using the Global Fund, and this is the grant that funds most of the HIV activities in Malawi. Yeah, and the only reason that we are not able to access these reagents, it was because the reagents were labeled for research use only, yeah, and they were not WHO pre-qualified. So other than this routine program monitoring, we also had a surveillance, that was a study that we conducted in 2022 to 2023, where we looked at DTG resistance. Yeah, so this was a cross-sectional study that we conducted in 18 facilities. So initially we selected 25 facilities with high volumes of patients in terms of patients that are on a dolutegravir-based regimen. So out of 25, we conducted this surveillance in 18 sites. Yeah, and we included adults that were 15 years and above, and then they were on a dolutegravir-based regimen for at least 9 months. Yeah, they have a high viral load. That's a viral load of 1,000 copies plus. Yeah, and of course, they have had at least one session of intensive adherence counseling. Yeah, and sampling was done using the total number per site proportion based to the volume of patients that are on dolutegravir-based regimen. So samples were collected from July 2022 to February 2023. Yeah, mainly we used plasma samples, and after collecting the sample, we also conducted a confirmatory viral load test just to be sure that the viral load is still on the higher side. Yeah, and then the ones that had a viral load of 1,000 copies plus are the ones that we conducted genotyping, and we used the HIV-1 genotyping, protease and reverse transcriptase inhibitor kit manufactured by Thermo Fisher. Yeah, on data analysis, we calculated the mutation scores using the Stanford HIV drug resistance database. Yeah, we used the 95% confidence interval. Yeah, so in terms of the study flow, we managed to recruit 1,035 patients that for the adult arm. Yeah, and out of that, as I mentioned, that after collecting the plasma sample, we initially conducted a viral load test just to see that if the patient still has a high viral load. Yeah, so out of 1,035 patients, we noted that 79.4% suppressed the viral load after that intensive adherence counseling. Yeah, and only 20.6%, that is equivalent to 213 patients, are the ones that did not suppress, and those are the ones that proceeded to genotyping. Yeah, and out of 213, yeah, we managed to genotype for 99.5% of the patients, and that was equal to 212 patients. So just a bit on some demographics. Yeah, we noted that median time on ART before people develop, or for those that did not suppress on DTG, yeah, it was 7.3 years. And then dolutegravir-based regimen at initiation, we had 86% of the patients that did not suppress. This did not start with a dolutegravir-based regimen, but only 14% are the ones that started with a dolutegravir-based regimen. Yeah, but more importantly is the median time on a dolutegravir-based regimen. We noted that the median time that it took for those that did not suppress was 2.5 years on a dolutegravir-based regimen. On the overall mutations, we noted that 15% had a major or minor INSTI mutations in this population group. And then looking at the actual mutations, you notice that NRTI mutations were almost 2/4 commoner compared to the NRTI mutations. And then for our INSTI that we are focusing on, we noted that 8% of the patients, they had dolutegravir resistance. But then interestingly, as a country, we have never used cabotegravir up to this time that we were conducting surveillance. But in this study, we noted that 9% of the patients, they also had a cabotegravir resistance. So on the actual mutations, we had 4% of the patients that were found with G118R, and 4% of course was also found with E138 AKT, and we had 3% that was found with R263K. So on the clinical observations, yeah, we noted that only 5.2% of the patients are the ones that started with an ART regimen based on DTG. And we noted that 31.6% of the patients, they were previously switched to atazanavir or ropinavir, as a second line, and then from there they were now transitioned to DTG, and 94.7% of the patients were transitioned to other regimens before being transitioned to dolutegravir, but without confirming a suppressed viral load status. And only 5.2% of the patients had a documented history of a treatment interruption. So as key points, we know that there is an opportunity to reduce attrition along the cascade of HIV drug resistance monitoring in Malawi. And of course, we also noted that there are a higher dolutegravir resistance prevalence rates in routine program monitoring compared to the surveillance that we conducted. That is, if you look at the routine program data, you are seeing something like 27 to 30% compared to 8% that in the surveillance. And of course, we have these three mutations that are commonest among the people that were found with dolutegravir resistance. And of note, 92% of patients with dolutegravir resistance, they suppressed their viral load after a regimen switch. And of course, we also noted that high rates of viral load resuppression were present in this population that we studied, and that suggests that most patients would benefit from a continuous adherence support rather than a regimen switch. And as a way forward, obviously, we need strategies to reduce attrition along the HIV drug resistance testing cascade. And of course, we also need closer monitoring in terms of evaluation of DTG resistance patterns. Of course, not forgetting a continued adherence support for that are failing ART in general or a dolutegravir-based regimen. And of course, for those that fail dolutegravir, definitely we have to facilitate a regimen switch. Informed by the results that are coming from the HIV drug resistance testing. And we are acknowledging these individuals and organizations, the HIV drug resistance expert committee in Malawi, for the technical support that they are providing in this routine HIV drug resistance monitoring. Of course, the US government through the support that they are giving the country in terms of laboratory systems strengthening, and of course supporting this HIV drug resistance testing in country. And of course the Ministry of Health, including all the staff and all the patients, and of course ITEC, Malawi and Washington that are championing the HIV drug resistance surveillance with support, of course, from CDC. Thank you for listening to my presentation. Now, let me hand over to my colleague, Dr. Kingwara from Kenya, to take you through the next part of the presentation. Over to you, Dr. Kingwara.
Thanks, Dr. Matola, for the kind introduction, and the lab group for giving me this opportunity to present our study where we assess the frequency of dolutegravir resistance among ART-experienced viremic patients in Kenya who are on DTG-based ART. This is my disclaimer for the study. So just to give you a little background on the DTG resistance in resource-limited setting. So recently, I think from 2017 to 2018, DTG and other high genetic barrier insulin regimen have largely replaced other antiretroviral treatments and regimen for HIV infections. This in the background of the WHO recommendation that DTG-based regimen be used as both first-line and second-line therapy for HIV infection. Why? Because of the high treatment success rate in DTG for both first and the second-line patients, and also because of its high genetic barrier and its high tolerability among the patients. After the WHO recommendation, there has been large-scale rollout of DTG-based regimen in resource-limited setting, and TLD and other DTG-based regimen have been recommended as a national policy guideline in treatment-naive and treatment-experienced patients. This is a slide from the recent CROI 2024 presentation that has been presented by Dr. Gad, where he presented the information from the recent International Workshop on HIV drug resistance and treatment strategies workshop in South Africa in September 2023. In that workshop, in most resource-limited countries, patients were blindly being transitioned to DTG-based ART, irrespective of being viremic on their current ART regimen. And patients have increased time to DTG regimen with limited viral load monitoring because of the PSM issues that followed, and that was also worsened by the previous COVID pandemic. In this, at this workshop, it was shown that there were emerging reports of the high proportion of the DTG resistant in some of the observational and laboratory-based studies that were coming from the resource-limited setting. These are recent IS mutation lists, and the list indicates the most common INSTI mutations. In the recent report, it shows that patient starts with DTG ART on the first line. The first three common mutations arise at position 118, 148, and 263, as highlighted. So based on that, as a country, we assess the frequency of DTG-based resistance among viremic patients in Kenya who are receiving DTG. Kenya rolled out dolutegravir-based ART in the year 2017 as the first and the second line treatment for PLHIV. So to assess the DTG drug resistance, we tested plasma sample from viremic participants as part of the CADA surveillance, mainly from the 9 counties in Western Kenya that were collected between January to March 2023. The map on the right shows 9 counties of the Western Kenya where majority of the samples were obtained. And it's also good to note that the area bears 70% of the HIV burden in the country. Participants' demographic and treatment data were obtained from the National HIV viral load testing program, and HIV-DR genotyping was performed on plasma samples with viral load above 200 copies per ml. We obtained 190 plasma samples from individuals on DTG-based ART for the CADA surveillance and assessed the frequency of INSTI HIV drug resistance in ART experience, shown in the pink boxes, and ART naive individuals, shown in the green boxes. 149 samples from individuals are shown on the right who were treatment experienced. This means that these individuals were treated with NNRTI or PI-based ART before being switched to a DTG-based ART. 41 samples from individuals shown on the left who were ART naive were initiated on DTG-based ART as their first-line ART. We had fewer individual samples who were ART naive compared to the ones that were ART experienced. So this table summarizes the demographic details of the ART naive and ART experienced individuals. As you can see, there was no difference in age and gender among the two groups of individuals. However, the ART experience had longer duration on ART compared to ART naive individual. The time on DTG-based ART for both groups were not statistically significant. So using a viral load cutoff of 200 copies per ml, we identified 42 samples from the ART experience and 13 samples from the ART naive individual. As you can see, in both of the groups, approximately 70% of them achieved viral suppression while on DTG-based ART. 31 out of 42 ART experience and 12 out of 13 ART naive individuals were successfully sequenced. One of the 12, which is 8.3% of the ART naive individual, had INSTI mutation, while 7 out of the 31, which translates to 22.6% of the ART experienced individual, had got INSTI mutation. Therefore, the frequency of INSTI HIV-DR mutations was higher in ART experienced individuals compared to the ART naive individuals. With that, summarize a table where we show the 8 individuals that had the INSTI-DR mutations, 7 ART experienced in pink, and 1 ART naive individual in green. Each column in the table shows information on 1, the ART experience before DTG ART, the ART regimen before the switch to DTG ART, and the duration of treatment, the duration on DTG ART, the current HIV viral load, and the major INSTI mutations, with the impact of this mutation on DTG resistance as based on Stanford algorithm. As you can see, majority of the individual had multiple INST-DR mutations detected that predicted high level resistance to DTG. Among the INST mutations detected is E138K mutation, which was the most common mutation, and this has similarly been identified with Dr. Matola that presented before me. Also to note that these 8 individuals with INST mutations also had detectable multiple NNRTI or NRTI mutations, as shown in the table. Okay, so our study showed that among the ART naive and the ART experienced group, there was no difference in age and gender, and approximately 70% had suppressed. The ART naive had a shorter duration on DTG, that's a median duration of 1.5 years, compared to the ART experienced that had a median duration of 2.1 years. For the resistance mutation in the 2 group, the ART experience had a higher, that's approximately 23% of HIV integrase transfer inhibitor resistant mutation, and 5 conferred high level resistance to DTG. That's higher compared to the ART naive individual. For the ART naive, it was 8%, and they confer intermediate resistance to DTG. All the 8 INST mutations harbored additional NNRTI mutations within them. So in conclusion, our study shows that the frequency of INST HIV-DR was higher among the viremic ART experience at 22.6% compared to the ART naive at 8.3%. Therefore, the data suggests the risk of DTG-DR mutations may be higher among those with a background of pre-existing mutations. The study emphasizes the importance of strengthened viral load testing program and HIV-DR monitoring among the PIL-HIV on DTG-based ART. The limitation of our study was that it included a small sample size and the use of convenient sample, which limits the determination of DTG drug resistance among viremic PIL-HIV at a population level. I would like to appreciate my colleagues at the Kenya National Public Health Institute who've helped me in doing the work, the study participants, and the National AIDS and STI Control Program that manages the care and treatment program that support the study participants. Otherwise, thank you. I would like to invite the next presenter, Professor Francois Venture, who is going to give us the next presentation titled "What Keeps Me at Night About ARV Resistance."
So hi everybody, I'm Francois Venter. I'm a physician based in central Johannesburg with a lot of experience in HIV programs. I ran a very large PEPFAR program in South Africa and have been advising and thinking about HIV resistance for a very long time. And I was asked to think about and talk about resistance and comment on the 2 excellent programs and 2 excellent presentations you've just heard from. So I'm going to just specifically talk about integrase inhibitor resistance in the context of broader resistance and what we've learned in the context of non-nucleoside reverse transcriptase resistance over the last few years, and what we're seeing starting to crop up now. Is to thank Thermo Fisher Scientific for sponsoring, and this is just their disclaimer. And my own disclosures in terms of who funds my units and myself. So to get started, the combination of tenofovir, 3DC, FTC, and efavirenz has served us really well. And it's been around in one form or another since 2010. And before that, various combinations of NNRTIs with D40 and AZT since 2002 in low and middle income countries have served us well. And we've got very used to this sequencing from NNRTIs into protease, boosted protease inhibitors, either lopinavir or increasingly into atazanavir, and combining that usually with AZT. And for a couple of countries, particularly places like Zambia, Botswana, South Africa, some of those countries have been lucky enough to even have third-line regimens. And the sequencing between first line, second line, and subsequent line has been incredibly successful. And I think we've all got pretty used to how this has worked out. And it's worked pretty well. And it's been quite predictable the levels of failure and the levels of virological failure and the levels of genotype resistance that have occurred, particularly to NNRTIs. And it's varied. I've put down here, it's been roughly 10 to 30% annually. Usually in well-performing programs, it's about 10%. In some poorly performing programs, and certainly in some rural areas of South Africa, which I'm familiar with, it's as high as 40, 50% efavirenz resistance. It really does depend on where you're working. We'd see patients failing, and most of those would be failing with resistance. We'd see usually a pattern of NRTI resistance with efavirenz, followed by 3TC or FTC where it was being used. And then finally, we'd see resistance to tenofovir. As I said, it was a very predictable process. And I think many of us involved in processes with this process were quite comfortable with seeing how this unfolded. And we were seeing the rise of NRTI resistance within our programs, as you would predict with a very low level of resistance required for failure with efavirenz. But then the whole world changed with the introduction of dolutegravir, and I'm not going to labor the point. Bictegravir, which is used in richer countries, is an analog of dolutegravir. Honestly, there's very, very little to choose between the two drugs. There are nuanced differences, but dolutegravir has been an amazing change in how we do business in the antiretroviral landscape. And with the introduction between 2018 and 2019, the WHO guidelines, we've completely and fundamentally changed how first line is thought about. Second line has transformed, and certainly in South Africa, where we've had a massive second line program, the numbers have dropped dramatically of patients on second line, where we've shifted them from the old second line onto the new first line. And even in third line, the majority of patients have ended up on dolutegravir-based regimens, have moved off third line regimens. So this has really transformed antiretrovirals as we've known them. So how has this dolutegravir, this huge new experiment of replacing efavirenz with dolutegravir panned out? Well, it's replaced efavirenz, as I said, and the side effect profile has been better. And we knew this. This was one of the big reasons to replace it, was efavirenz was, I think as we gained more experience, we realized a lot of our patients were being quite stoic about their side effects. Some of the more serious side effects that we were worried about with dolutegravir, the neural tube defect sign that we saw in the initial sign from the Sepama study in Botswana, was resolved. And I think we're pretty happy with the pregnancy safety signals around dolutegravir. There's been some case reports from Uganda and some of the countries in Central Africa around diabetes, but these case studies haven't really been confirmed, and we haven't seen it from the clinical trials. So it's still speculative around the link between dolutegravir and diabetes. And the weight gain that we've seen from dolutegravir containing regimens, we now know is not due to dolutegravir. It's actually from the fact that our modern antiretroviral regimens are so well tolerated that when we introduce people back into a very obesogenic environment, that they start gaining weight. So there's been really elegant research done by the University of Cape Town to demonstrate that dolutegravir is actually not implicated directly in weight gain. It's association, not a causation. There's also much better persistence, and the large PEPFAR cohorts have shown remarkably how much better dolutegravir is than efavirenz, and patients really stick on this drug much better than they did on efavirenz. And at this stage, we've got tens of millions of patients who are accumulating years of data on dolutegravir, and with it has come what we're going to see now, and what you've just heard from Kenya and from Malawi, is resistance data, and it still has we've seen some worrying data, as you've seen from the last two countries, you guys see in a moment, but the resistance profile is remarkable compared to efavirenz. As I said, that even in the best performing programs, we were seeing 5 to 10% resistance with every year. And we're not seeing anything approaching that with dolutegravir-based regimens. And finally, it's cheaper, and the price of annual treatments, and again, these numbers are from South Africa, they're actually slightly cheaper in many other African countries. The price of annual therapy has dropped from $110 to around $60 a year for first-line therapy. So efavirenz-based regimens in South Africa were around $110 when we made the transition. And I was told in the last 2 weeks that, in fact, dolutegravir-based regimens will drop to about between $50 and $55 a year for first-line therapy. So that's absolutely remarkable when you think of where we came from. In the old days, when Cipla introduced D4T-based regimens at $1 a day, that's over $300 per year. So this has been a massive public health success. It's not often you get a better drug that's safer, more potent, and is cheaper in medical terms. In fact, I battled to think of a single time that this has actually happened. So can we all rest easy? And can we say this, we can all go back to thinking about other problems in our healthcare systems? And obviously we wouldn't be having this seminar if that was the case. And to start off, I'm going to rely heavily on a resistance meeting that occurred a few months ago in Cape Town that had a lot of this resistance work done. And there's been a few odds and ends have come out in the literature since then, which I'll touch upon. And some of that resistance data that was in the meeting was presented in the Malawi and Kenya presentation that you just heard. So Bob Schaefer, who is one of our great resistance doyens in the field, presented at this conference, and what he talked about was these signature dolutegravir resistance mutations. Now, the integrase inhibitors are not all made the same. There's some which are easy to break, very similar to NNRTIs, where some are easier to break than others. Some are moderately easy to break, like cabotegravir, which we're all starting to hear all about in the PrEP world. And then some are very hard to break, which is dolutegravir and bictegravir. And these four major dolutegravir signature mutations, you can see here, are actually quite complex. And Bob presented these four and demonstrated how complex they are in terms of their genotype, and how they perform, genotype resistance, and how they perform in the field. So once you get one, some of them are remarkably crippling, and others are much less crippling. And some of them in combination are very, very crippling, and others are barely have any impact whatsoever on how the virus performs. And this is, many of you will see this and be familiar with this when it comes to, say, for instance, the thymidine analogs, and even the NNRTIs, and see how things aren't, the old way of thinking about resistance as all things are the same is not the case in the case of integrase inhibitors. And I'll come back to this in a moment when we talk about the resuppression data. And you actually saw some of that in the presentation, saying many of the patients resuppressed despite having resistance. So you've seen this data in Africa. So I'm going to show you some of the newish data that came out from the conference and subsequently. So Bob also did the second presentation, and he tracks this all the time. He's really obsessive about following integrase inhibitor resistance, and he's a great resource for the community, actually, because he really follows it closely. And he pulled up this, what's the systematic review, where he pulled up all the cases of integrase inhibitor resistance in patients who were naive to integrase inhibitors. They might have been exposed to other classes of antiretrovirals, but in this case, we're naive to actual integrase inhibitors. And he found many studies, and these were cohort studies, there were case reports, they were clinical trials, there were everything you could possibly think about, and pulled all of them out. And you can see some of them were, as you'll see in the next slide, some of them were big, over 4,000 patients. Some of them were just small, as you'd expect from case reports. And you would imagine that patients in clinical trials, you could see that, and as we know, the resistance levels were extremely low, if they're at all, in patients who were introduced to dolutegravir. And in my own studies, the advanced study, which we were a part of, where we didn't actually see a single case of dolutegravir resistance, you can see the clinical trial data was very reassuring. There were so few cases identified in low and middle income countries, even in the cohort data, that you can see he made this comment that we actually just need more data of virological failure. There were cases identified in case studies and all the rest of it. But it's very messy out there. And, he was just busy assembling all of this as we went along. Lucia Hans, who runs the resistance lab in South Africa, has access to quite an interesting cohort, which is probably different from anywhere else in the world. Firstly, South Africa is a middle-income country, so it does have access to limited genotype resistance testing. Also, the South African program is massive. It's also, I'm sorry to say, it's slightly chaotic as opposed to the well-run Botswana program. So because of that chaos, you do tend to see a situation where you're more likely to get potential resistance. And what she demonstrated with sequential sampling of the patients sent in for what she would do is take patients who are viremic and sample every seventh case over a period when the dolutegravir was introduced. Dolutegravir actually entered the South African program relatively late compared to most other African countries. But you can see here over this 2019, 2020, 2022 period when it was introduced, that there was a steady rise in dolutegravir. And what's really useful about her data, which was presented at the conference and which she's still busy trying to put together, is the fact that actually doing dolutegravir levels is a very useful way of excluding, firstly, the patients who weren't taking any form of therapy, and I'll come back to that in a moment, but also patients who were not taking sufficient therapy to actually generate sufficient drug pressure to induce resistance. But she did demonstrate a small increase in the amount of dolutegravir resistance in the patients that they were starting to do genotype resistance testing in the patients presenting themselves to her laboratory. In a large collaboration across high-income and middle-income countries, you can see the countries from 8 cohorts: Canada, France, Germany, Italy, the Netherlands, Switzerland, South Africa, and the UK. So quite a diverse group of places where they just looked at patients who had genotyping done on viremic patients who had genotype testing done on patients on dolutegravir-based antiretrovirals. They actually found incredibly small number of patients out of the 600 that they did genotyping on with any form of actual integrase resistance testing. They initially found 86 out of the 600 odd, the 599 they did testing on, who had actual integrase resistance identified of any form. But they only found 5 out of 6 but they only found 6 with high-level dolutegravir resistance, and 5 of those 6 had actually been exposed to all sorts of strange regimens, either monotherapy, some of the monotherapy studies that have been done, or dual therapy, or had been exposed to very poor activity in terms of the NRTI backbone. So again, you could ask yourself, out of those 600 patients, they actually found 1 patient who had significant resistance, who didn't have some sort of strange background history. And for us in public health programs, you could turn around if you're a complete cynic and say, you resistance people are being a bit hysterical. That's 1 out of 600. That's a very low percentage. And those were only patients who were viremic. That's a much less than 1%. That doesn't sound like much of a problem to anybody who's based in Africa. Why are you going to waste all this money and energy? We've got a lot of other problems we need to be thinking about. Do we have a problem? And that does come down to it, because we do in the antiretroviral program, in the HIV program, have a lot of other problems. We have advanced HIV disease. We have patients who lost to therapy. We have adherence issues where people are viremic with no resistance. There are lots of things we need to be worrying about that aren't necessarily worrying about resistance. And I would argue that it is important that people do take stock of these things, and that we do acknowledge that knowing about this is important. And we can see the problem is growing. And I think that certainly the South African program is demonstrating it, the Kenyan program is showing it, the Malawian program. And there were other presentations at the resistance conference a few months ago that demonstrated that the problem's there. It's not escalating at nearly the same speed as the NNRTI resistance we saw with the efavirenz and the nevirapine, but it's there, it's growing slowly, and it'll probably continue to grow slowly. I don't think it's going to escalate at nearly the same scale, but it's there. And if we keep denying it's there, you start undermining the adherence programs. Clinician trust starts to erode. When you see a result and you tell them, no, it's not resistance, people know there's a small chance there's resistance. it's not a good thing to tell clinicians they're stupid or that they're wrong. You need to be able to give all sides of the story, even if it's a small charge. You need to be able to entertain the idea that might be resistance that's actually causing failure. And it also calls into questions, why are you doing surveillance at all if you think there is no resistance? And all of these things are important to acknowledge when you're talking about a case. And I'll come back to some of the cases that we're seeing at the moment. Also, we're having injectable cabotegravir, and some of the programs we're being introduced. I heard that the 100th case was started in Cape Town in one of their, just this week, on one of their large programs. 2,000 women have been given cabotegravir in Zambia. So cabotegravir is coming out there for PrEP, and we've got a whole of long-acting agents being introduced, which are very likely to include, initially at least, cabotegravir and probably new injectables, integrase inhibitors. So we do need to be thinking about what this means. But we also need to acknowledge what a massive problem this holds for, in terms of a knock-on monitoring problem for all of us. And it's really a needle in a haystack, and it's a very small needle in a very large haystack. We have to do a lot of viral loads to find a failure, and I think we all acknowledge the fact that waiting for immunological failure, using CD4 counts, or even worse, clinical failure to find clinical failures is not what we're going to be doing in this day, and certainly not in 2020 for any of our programs. I think that what we're going to be looking for is virological failure. Now, just using the South African program as an example and anticipating that we're going to have to do genotyping to confirm resistance, there's just no real other way of doing this at this time. Let's say you've got this 1% of the South African program now starts to fail annually. And I must still point out that even with dolutegravir, it's still high. It's probably sitting at about 5 to 10% in the better parts of the country, even with dolutegravir. We've got 6 million people on treatment. That translates into 6 million viral loads annually, which means even if 1% are failing, that's 60,000 viral loads we're going to need to confirm the failure. And even if we get half of them to suppress, which is a lot, I would argue, that still means another 30,000 genotypes that we're going to have to do per year. And that translates into a huge amount of money that we're going to have to allocate for genotyping, as well as 30,000 genotypes are going to have to be performed in a laboratory that's probably doing 3,000 to 4,000 at the moment. And Kim tells me that she's able to do that, but it still means scaling up significantly beyond our current capacity. So it's not as if this is a negligible amount of resources we're committing to making this way. So we've got to start thinking, are there better ways of doing things? Do we do this before they even get to the stage of thinking about doing a viral load? Is there a better way of identifying who needs a genotype? How do we make sure that they're actually taking their drugs in the first place? And Kim's data does suggest that a large number of patients are not even swallowing their drugs. So can we find who's taking their drugs? Can we find who's viremic, who's aviremic? Are there clever ways of doing this? Can we find somebody who's got resistance in the first place before we go to a very expensive genotyping test? Are there smart ways of getting past this, pre-identifying these patients before we take them right through to these significantly more expensive tests? And can we we've been talking about using hair, we've been talking about using blood, urine, using tenofovir, using dolutegravir. And luckily for us, there are lots of smart people who've started to work on this. And it was amazing to me at this resistance workshop, because a lot of these smart people were there presenting their work. But even since then, and some point you to this field performance test down there published in JIS just a few weeks ago, there are lots of people doing this kind of work who's starting to think about this. And we're going to need them to be working hard, because that needle is, as I said, it's a very small needle and it's a very big haystack. And our current algorithms, I don't think, are going to be working for it. So just my final slide is thinking about what now. And I think we have to find those needles in the public health approach, and we're not going to be able to throw genotypes at every single person who walks through the door who's viremic. And this is where the smart thinking is going to have to come. And denying there's a problem isn't one option. We're going to have to think of a way past this. I certainly don't have easy answers, and I'm hoping that some of you do in the audience or on the panel or wherever else. We also need to think harder about what this adherence intervention is. You know, you've heard that the adherence intervention works in other programs. We've certainly seen it ourselves. On the advanced study where we went in and we didn't stop the dolutegravir, we just went and essentially intensified adherence. Like we just spoke really hard to the patients, said you really need to swallow your tablets. Almost all the patients re-suppressed. But we need to give content to that. You can't just say to people, you know, have an adherence intervention. There's very little content to what we've actually said about that. And I suspect what works in rural Malawi is very different from urban Johannesburg, is very different from whole chunks of Africa. And we need to start thinking about what that content is. And then I think we need to know what the actual implications of the various dolutegravir resistance mutations are. Does that mean that patients won't suppress? Like some of those mutations look terrible. Like some of them look, you know, like they're very crippling though. So some of them might mean that we don't need to change into our regimens. And then think, what is the best next line? You know, for my eye, the only thing we really have is a boosted protease inhibitor, and those drugs are very expensive and relatively very toxic. Multiple tablets, twice a day. I'm not sure where this is going to fit in the practical program. And what does it mean for cabotegravir when we start rolling it out at scale? Luckily, that's a couple of years, well, not luckily, but unfortunately, it's a couple of years away. It looks only 2027 we'll be getting cabotegravir at scale. But we must start thinking about that, is how's it going to impact on the programs? And we need those studies to start happening. And then my final point is, we've seen CARES, this study that's shown that rilpivirine and cabotegravir in combination worked really well. Beyond anything I thought was possible, where patients who were suppressed were moved onto injectable rilpivirine and cabotegravir. We need to anticipate that these injectables are coming. And what does that mean for these patients who might have low-level resistance? What are we going to do with these patients? Now, I've referenced the CROI abstract that you might want to see. And then there was a publication that was just released in CID just this week, which looked at superinfection. I haven't thought or worried about superinfection for over a decade. And for the first time, we've seen a patient, again, somebody who's on cabotegravir rilpivirine, accumulate what looked like a superinfection that broke through the cabotegravir and rilpivirine. And we need to start thinking about, if this is possible, as we see a new wave of these new injectables and long-actings coming along, what does it mean for Africa? How are we going to deal with this? And these needles in the haystack, how are we going to find them, identify them, and move them onto appropriate therapy, prevent them preferably in the first place, but move them onto appropriate therapy after identifying them efficiently as best we can? And these are hard questions for us after a couple of years of an amazing drug. I think the things we're going to have to work out as quickly as we can. And I look really forward to your questions. And I look really forward to welcoming onto the panel my previous speakers who can help me along to try and solve this along with the rest of you. Thank you so much.
Thank you again to our presenters today, Drs. Matola, Kingwara, and Venter, for sharing with us this important data and your insights into this topic. We've received lots of questions, and I want to encourage the audience that if you haven't already submitted your questions, please do so now. Just click on the Ask a Question box located on the far left of your screen. We'll answer as many questions as we can now, and then we'll take the other questions later. So now jumping into the questions, I will start with prevention, which Professor Venter spoke about, injection cabotegravir for PrEP. Dr. Venter, can you just kindly explain to our audience what the correlation between cabotegravir and DTG resistance is, because that's something that has come up in most of the presentations today.
We have very limited data yet on this, and the worry is that cabotegravir has got a lower resistance barrier than dolutegravir, but the concern is that the failures of dolutegravir as treatments has largely been seen with people who've been exposed to other integrase inhibitors, predominantly raltegravir, which has a relatively low resistance barrier relative to dolutegravir. So the fear is, our worst nightmare would be to give cabotegravir to lots of people with PrEP, and cabotegravir has this very, very long tail, have breakthrough infections, people to accumulate cabotegravir resistance, and then go on to dolutegravir-based first-line therapy and to fail their dolutegravir-based therapy because they've accumulated cabotegravir resistance. So this is the public health nightmare that people have imagined happening. And we just don't know if that's true because, as I said, we don't quite know what the impact of the integrase inhibitor resistance mutations are once you intensify adherence and once you actually go in hard with dolutegravir and you actually swallow all your tablets and you take them optimally. So, but this is what the concern is that people will not suppress on dolutegravir once they fail cabotegravir. And because of this long tail, people are particularly perturbed. So there are studies being designed and to study this over the next while. But as I said, cabotegravir entry into Africa is going to be delayed significantly because the volumes are only going to increase in 2027. And even then, they're going to be small. Generic large-scale access is probably only going to start significantly increasing 2028, 2029. So we do have time to work this out, thankfully. But it is something that is probably going to contribute to community resistance in the future, at least somewhat.
Thank you so much, Dr. Venter. And for the other speakers, if you want to add on to the answers from a previous speaker, please feel free to, and we'll just go on, and if no one has something else to add. So speaking about adherence, which was just brought up, we saw from Malawi's data a significant improvement or significant drop in, or significant resuppression actually of participants on adherence strategies, right? And so right now I want to just, ask Dr. Wilson to give us insights into some of the successful adherence practices that Malawi has undertaken. I know that, context will differ, but how is Malawi doing it? Are the nurses taking care of adherence? Is there, a process of adherence that, people can actually implement in their own context?
All right. Thank you very much, Dr. Obi. Yeah, so for Malawi, it's not that our adherence is perfect. We are also struggling with retaining patients in care. Yeah, for example, at 12 months, we are talking about a retention of around 83-82%. Yeah, but now what's working well in terms of keeping patients in care and making sure that they are adhering to treatment, is the peer-led approach in terms of supporting them with adherence. Yeah, we have what we call expert clients. So these are people living with HIV that are on treatment, that are virally suppressed. So these ones are the ones that support their peers who are not virally suppressed. Yeah, in terms of how they can do it and how they have done it from their end. So that one seems to be working. Yeah, and then in addition to this, we also adopted the WHO undetectable is equal to untransmissible. Yeah, so that sort of campaign and approach gives people vibe to make sure that they're taking the ARVs. Yeah, so if this is, let's say, a pregnant woman, when they get this message that if you have a suppressed viral load, it means you will not transmit the HIV infection to your unborn baby. Yeah, that's also a sort of gives them encouragement to make sure that they are adherent to treatment. Yeah, issues to do with healthcare provider attitudes. Yeah, in the 2022 guidelines, we specifically tackled this issue because we have had some research, I think it was from Zimbabwe, where they documented healthcare provider attitude as one of the barriers in terms of keeping patients in care. So we specifically addressed that in terms of making sure that healthcares, they do welcome these patients with this sort of enthusiasm. Yeah, that's not judging them, for example, if they have missed an appointment and anything in those lines. Yeah, additionally, we have also made sure that we adopt regimens that are very tolerable in terms of minimal side effects. So the dolutegravir-based regimens, they are doing well in terms of that aspect. Yeah, and then we have also tried, and we keep on trying in terms of reducing stigma and discrimination as it regards to HIV/AIDS, because this was also found to be a barrier in terms of keeping people in care. So mainly those are the initiatives that we are working on, yeah, in terms of improving patients' adherence. So as I've said, yeah, it's still a work in progress. We cannot say that we have a perfect program in terms of this. Yeah, we are still losing some patients from care because of these same adherence issues. Over to you, Obi.
Thank you. Thank you so much, Dr. Wilson. So the next question is actually jumping into the topic of HIV drug resistance, and it would go to Kenya. And so the Kenya surveillance data that was presented showed that the viral load that was eligible for HIV drug resistance testing, at least in that surveillance study, was 200 copies per mil. So I want to ask Dr. Kingwara, why 200 copies per mil, given that, you know, the WHO recommends 1,000 copies per mil? That's the first question. And then the second question regarding that is, with the findings of drug resistance, indetectable but suppressed. So 50 to 200 copies per mil is, we say it's detectable, but at least it's suppressed below the WHO 1,000 copies per mil limit. With that finding, is there a need to revisit the definition of virological failure? Because if you are seeing virological failure and resistance in 200 copies per mil, and we are all still using the 1,000 copies per mil, should we be revisiting that? So Dr. Leonard, I'll hand over to you first to answer why 200 copies per mil, and then we'll open it up for other speakers to answer the next question.
Okay, so the Kenyan guideline still uses 1,000 per ml cutoff to assess whether somebody is failing treatment or not failing treatment. In addition to that, we have a category of what we call like high risk, low level viremia, whereby we monitor between 400 to 999. And then after that, they included, initially we had high risk and low risk, low level viremia, but initially they mapped them all together as low level viremia. So as our care and treatment guideline monitors what we call like the low level viremia between 200 copies and 999 copies. And then after that, so if you are between 200 and 999 copies, you are also being enrolled into what we call the low level, the viremia clinic. One of the main things that was observed is that most of the people who are persistently having low level viremia were more likely to be failing treatment. So based on that request, what the program did was that they requested the lab to do for them a validation of the kit that we are currently using, so that we can be able to assess whether we can be reduce the sensitivity of our assay from the validated threshold of 1,000 copies to 200 copies per ml. So what we did is that we did our validation, and then we picked samples with certain mutations. We did our dilutions up to lower copies per ml, and then we were able to show that the dilution between 200 to 999 copies, we were still able to pick the same mutations that we were able to pick at about 1,000 copies. So for the purpose of supporting the management of patients that have the low level viremia and that are in the viremia clinic, and also to support our care and treatment guideline, we managed to validate our assay so that we could be able to sequence from 200 copies and above. So that doesn't mean that we've gone against the WHO recommendation of definition of viral failure as above 1,000. No, viral failure is still above 1,000, but so any patient above 1,000 goes to the viremia clinic, but also because of the high chance of patients, especially between 2 and having low level viremia, to eventually fail treatment, these patients similarly also go to viremia clinic. So we also do monitor them by viral load and also by drug resistance. Over.
Thank you so much, Dr. Kingwara. Professor Venter, the second question, maybe I will rephrase it given Dr. Kingwara's response. The second question would be, so thus in low-level viremia patients or individuals, what should we be worried about?
So I was part of the original group who selected that 1,000 threshold, what it seems like 1,000 years ago. And at the time, we were trying to balance, you didn't want to change everyone too quickly, because we had limited drugs and because second line was so toxic and was so expensive. So we didn't want to move everyone too quickly. And on the other hand, we didn't want people to sit forever on first line and develop resistance mutations. So you're trying to balance this, and 1,000 just seemed like a really good threshold. And as time came along, it actually transpired this was a great threshold because it was also the kind of level at which sexual transmission occurred. The kind of 1,000, 1,500 threshold. So it's kind of stuck around. The low-level viremia we've done lots of work on this, and so many other people have as well, predicts future failure. The problem is that low-level viremia also there's quite a lot of uncertainty at that level. So it can be 400, but that 400 might actually be 800, and that 700 can actually be 1,300. So there's, the PCR is not great at that level. And it's important to recognize that that 1,000 threshold is a little bit arbitrary. And I think what we probably going to need to start recognizing is that any form of viremia indicates a adherence intervention, and that we need to start acting upon it. Trying to explain that to the patients around transmission events and risk and things is important. But for all of us, I think trying to get our healthcare clinicians to start recognizing that low-level viremia must be regarded as something important and actionable, rather than, I think, in the old days, where it was possibly seen as a little less urgent. It should never have been that way, but I think it often was. Is going to be something that needs to make its way probably more firmly into the guidelines, and we need to start thinking about that a little bit harder. I actually wasn't aware of how much variability within the PCRs there actually was at the lower levels and around this 1,000 threshold.
Thank you. Thanks, Professor Venter. The next question will go to Dr. Wilson from Malawi. And the question reads that, as noted in the Malawi data, that there's a distinct difference between DTG resistance that was found in routine program monitoring, which was about 20 or 30%, versus surveillance, which was about 8%. I think you pointed it out in the slide. And so the two questions here. First is, which is closer to the true rates of resistance? And then the second question is, I know that surveillance has been used typically. So what is the utility or usefulness of having such clinical or individual level data in terms of, curbing this DTG resistance that is emerging?
All right, thank you very much, Obi, for that question. Yeah, so the DTG resistance prevalence rate that is reported in the surveillance, I think it's the one that should be closer to the true rate, because of the following reasons. The first one is that if you noted in the presentation, in routine program monitoring, there is around 62% attrition. That happens between applications that are received and then the actual samples that are collected. Yeah, so this automatically filters out clients that might have a unsuppressed viral load, and then due to either suboptimal adherence or anything in those lines, yeah, and then because of that, you are sort of reducing the denominator for DTG resistance prevalence calculation, and then you end up with a higher DTG prevalence rate. Yeah, so for example, on the slide number 12, we had a total of 87 applications that were received, and then 33 samples that proceeded to a laboratory. And then from those 33, we had 8 that were found with DTG resistance. Yeah, but in essence, all the 87 applications that we received, it means those patients qualified to have a resistance testing. Yeah, so if you take 8, for example, as a numerator, and then you take the total applications of 87 as a denominator, you notice that your DTG resistance prevalence comes to around 9%. Yeah, but because you are using the actual samples that were tested, yeah, and then that's how you end up using the 33 as a denominator, and then that's how you end up having 24% as the reported DTG resistance prevalence in the routine program data. Yeah, the same thing is also noted in the second analysis that we conducted, where we had a total of 317 applications, and then out of that, 119 are the ones that made it to genotype testing. And then from that figure, we got 24 that had DTG resistance. So if you take 24 as a numerator, and then you use that initial figure of applications that we received, you notice that the prevalence will be around 7.6. But then because you are using a denominator for the actual samples that have been tested, you are ending up having a prevalence of 27%. So if you take that 7.6% and then the 9% in the other analysis, you notice that this should be within a 95% confidence interval of 8%, which was the rate that was reported in the surveillance. Yeah, so that's what could be contributing to these differences. And then the other thing is the routine DTG resistance testing. Those applications are scrutinized by HIV drug resistance experts. So they look into other things like the documentation in terms of adherence. Was it done with fidelity? Are they convinced that now adherence is perfect? So that process as well filters out some patients that maybe they had a high viral load, and then it's just an adherence issue. So because of that, you sort of end up reducing the denominator, and then that's how you end up having a higher prevalence in routine program data. And then lastly, for the routine dolutegravir resistance testing, you notice that you have other facilities that utilize the service more. For example, urban health centers, and then tertiary facilities, they utilize the facilities more. Yeah, and then because of that, that sample is not nationally representative compared to the surveillance sample, because the surveillance is done throughout the entire country, whereby you sample patients from different facilities. Yeah, that's why I think that the prevalence of DTG resistance that is reported in the surveillance should be the one that is closer to the actual reality. Yeah, and then can you remind me the second question?
Oh, I was asking about the utility of the clinical or programmatic data versus the surveillance data. So how useful is clinical how useful is that data? Does it help the programs having clinical level data?
Yes, it helps the program, because sometimes it happens that you have information of that specific individual, for example, with resistance, And then you can really marry what happened in terms of the clinical history and the regimen history and the mutations that you are getting now. Yeah, I don't think that would have been possible in the surveillance mode, because there you have these issues to do with identifying the patients, and then it doesn't give you that chance of having that patient level history or patient level data for you to make a decision. Yeah, and then the other thing is with resistance, we have to treat it as a public health problem, because today you can say you're only getting, let's say, 2%, for example. Yeah, but if these 2% are men that are sexually active, or the women that are sexually active, yeah, you don't know what that can turn into, let's say, in the next 3 or 4 years. Yeah, so even the few numbers that we get, definitely we have to use that information clinically and make a decision in terms of managing the patients on the ground. Thank you.
Thank you so much, Dr. Wilson. The next question we have, Dr. Wilson brought it up about measuring and the denominator that is being used. I know that in the conference that we all referred to in December, the HIV drug resistance conference, there was a conversation around what the appropriate denominator is. We had people using, the number of total number on DTG. Some people use the number that were adherent. Some people use numbers that had taken DTG for more than 2 years, and all sorts of things. And so I think I would ask Kenya, since you're the head of the lab, what's the appropriate denominator for measuring DTG resistance? Or what do you think is? Maybe I shouldn't put you on the spot and ask what is. What do you think is?
The appropriate denominator is everybody who is on DTG, everybody who is exposed to DTG. So what we've done is that we've designed up our sampling frame. One, also to be able to get for us the prevalence of DTG resistance as per certain pre-selected age bands. We have 0 to 14 years, we have 14 to 19 years, we have 19 to 24 years, because there are different type of adolescents between that specific categories. And then we have above 25 years. And then we have sex. So we do stratification as per those specific age group. And then we also do stratification as per sex, so that we can be able to clearly identify what's actually happening. We do that because when we do our drug resistance survey, we also do the early warning indicator, such that we get the context under which we are reporting the specific data for the drug resistance prevalence. So we usually triangulate the drug resistance data with also the DR early warning indicator data that we have from the program. Our EWI captures the entire spectrum of the program, everybody within the program, regardless as to whichever regimen. But for the purpose of addressing the prevalence on DTG, I would propose is exposed to the DTG regimen.
Thank you. Thanks, Dr. Kingwara. Is there anybody who wants to add on to that?
Yeah, I think that's right. I think that it should be total exposure. I think the reality, though, is that there are so few cases that trying to characterize the cases that we see as well as possible, and what happens to them after we've exposed after we've documented, is going to be really important. So we know what's going on. Like I said, that one study that was in Lancet HIV showed one case that had high-level dolutegravir resistance that had no weird background history. It would be really interesting to know what happens to that case over time. So the other cases had monotherapy dolutegravir and dual therapy, and had really compromised nukes in their backbone. So I think it's, for the foreseeable future, we're going to have handfuls of cases, and we must chase these cases down and really find out what happened to them. Also, why did they fail? There was one case presented at the HIV Clinician Society meeting in October, which was very scary, because South Africa's gone down the route of only doing genotyping after 2 years of documented failure. You mentioned that earlier. And we thought that was a great idea, because we'd done that with the protease inhibitors. And we had a case presented where the patient failed with high-level dolutegravir resistance after 4 months. So that strategy is also not going to work. So we really are still learning very much on our feet at the moment about what we're seeing here. And I think that for us to accumulate as much good clinical data on these patients as possible is going to be very important. It's not just the genotyping we need. We need to know what's going on with them. Like, what was the journey? Why did they fail? Was it drug interactions? Was it poor adherence? What was it that was going on in this? And we need savvy clinicians to be documenting this for us as much as they can, and then following it after the failure and the genotype resistance to find out what happens to them in the end. I mean, to have data from, I think it was Kenya, which said 75% of the patients resuppressed. That is gold, for us to be able to work with at the moment.
Thanks, Professor Venter. And I think staying on you, you talked about drug exposure testing as being one way to selectively identify patients who are at higher risk of having resistance. However, I would note that the drug exposure testing is not yet readily available. And so in the meantime, the question is, what's the role of genotyping guided treatment in curbing emerging resistance as we wait for, drug exposure testing to be readily available?
I don't think any of us really know, because of the nature of, we don't know what the consequences of those dolutegravir resistance mutations are. And which is why following up patients with high level mutations and seeing, do they all resuppress or don't they, is going to be such important data for us. We can move everybody to a protease inhibitor, and we know that they're probably going to suppress if they take their medication, but we don't know if it's necessary. And to move somebody to a toxic, expensive, multi-drug, multi-day, multi-tablet regimen is a big decision. And is it something we can get away with? And we've already heard data here from our previous presenters that most of them will resuppress. What happens where we've got well-documented genotype data that shows that the virus is partially crippled? Maybe the adherence intervention is far more important than switching the drugs. Maybe it's all more important. Maybe it's all we need. And those are the things that we need to be working out now on the very few patients we have that have actually failed properly. And that's where genotype resistance is going to be important, because we're going to need that information out there to characterize these patients very, very well.
Thanks, Professor Venter. We have a question from Malawi, and based on the Malawi data, actually not based on Malawi data, but based on WHO's guideline for pre-resistance treatment greater than 10% to NNRTIs or PIs, that was set as the decision point, so to say, pre-resistance of greater than 10% or for surveillance data, and that was set as the decision point for countries to take action, so to say. And so the question is, should a similar approach be applied to INSTI as we start to think about integrase resistance? Should that be a set point of 10% or more, as was used previously, or what should it be?
All right, thank you, Obi, for that question. Yeah, I think this one will be very, very tricky, because we are just saying 10%, and then you have seen the complexities in terms of how we are coming up to whatever percentage in terms of the DTG resistance prevalence. Yeah, is that 10% of all patients that were sampled, or is that 10% of all patients that have been successfully sequenced? Yeah, of course, even the 10% in this context of DTG will be tricky, because we do have a small number of patients who, for example, we had intermediate level resistance to dolutegravir. And then when we doubled the dolutegravir dose, and then we supported patients with adherence, we noted that they suppressed. Yeah, so it will not be like a straightforward thing that the moment you are getting 10%, then that should automatically translate into now taking an action in terms of either considering a totally new regimen. I think it would be difficult because we have very different cases in terms of how they are presenting with the resistance. Yeah, there is that level thing, intermediate or low level, for example, or some maybe they were on a TB treatment that had, for example, rifamycins, they needed to double dose the DTG, that didn't happen. And then they're having a resistance. Now, when you double the dose, there's some that suppress very well. Yeah, so it's tricky in terms of making that decision. Maybe we need more data from research, of course, to guide us in terms of what should be the way forward. Thank you. Over to you.
Thank you so much, Dr. Wilson. And I think we have no more questions for now. And so I would like to give each presenter a minute to just close out if they have something else to add. And we'll start from Dr. Kingwara.
Okay, thanks. So mine would be, we really need to strengthen the viral load testing program, and we also need to ensure that we strengthen the drug resistant testing program. We need to do a close surveillance on everybody who is failing DTG-based regimen. We can't afford to lose it. If we don't do proper surveillance on it, then we may just lose it. Thank you.
Thank you. Dr. Wilson?
Yeah, from my end, I would still emphasize on adherence support. Yeah, because even if you diagnose that someone has, let's say, INST resistance, for example, what next? It means you have to put them on another regimen, either with more tablets or maybe with more side effects. Yeah, which means they'll still have to adhere to that regimen for them to suppress. Yeah, so my emphasis is on adherence support so that we make sure that we suppress this virus and win this battle. Thank you.
Thank you. Professor Venter.
Yes, I think we're going into a remarkably complex part of our ARV rollout. And I think there are two components, I think, as your previous speakers have mentioned, the adherence intervention, I think giving more content to that, making sure that, the primary healthcare level, we have something that our healthcare, our coalface workers can actually meaningfully give out, as part of that component, and stepwise approach to actually assessing people that is useful in this context, tailored. But I think lots of smart people are going to have to think about what tests are we going to need that are going to make our lives easier, that can be rolled out. And I think, genotype testing, conventional genotype testing is way too expensive and too difficult to roll out on scale, is always going to be restricted. How do we get to that testing in a way that other screening tests allows us to get there? And I think that we really are going to need very clever people in the laboratory and development arena, and then people involved in scale up who are adept at this to make sure, how do we get that to primary healthcare clinics? And again, the coalface workers start implementing that stuff to make sure that finally the people who do get genotype testing are rapidly evaluated and moved to whatever therapeutic strategy we identify as appropriate for them. So it's interesting times. We've got time, but we shouldn't stick around too long, because we are probably going to see a steady increase in integrated resistance coming into the region.
Thank you so much, Dr. Venter. And so before we go, I'd like to thank again all our speakers today and the audience for joining us. Questions we didn't have or we didn't have time for today, we can submit all those and they'll all be answered on the on-demand period. And we will contact each participant with a question via their contact information at the time of registration. I want to add also that this webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay, and we encourage you to share this email with your colleagues who may have missed today's live event. And so until next time, bye.